Hello, my name is Majid Alaboud and I am an endocrinologist and I will talk about treating obesity as a disease. What are the underlying causes? So, first of all, I would like to disclose that majority of my slides are by courtesy of Medscape. Let's start with the introduction. Obesity has been described as a risk factor for a number of other diseases like hypertension, diabetes, hyperlipidemia, etc. But it might be more appropriate to consider obesity itself as a disease, as a chronic condition with a number of associated complications such as diabetes, cardiovascular disease, liver disease, respiratory disease, cancers, as well as osteoarthritis and many other conditions. Such a consideration may change current notions of how best to treat obesity and will make life easier for the patients as well as the treating physician and the stakeholders or the authorities. If we success to change this notion of considering obesity a, a chronic disease rather than a risk factor for other disorders, the patients will be easy for them to go to their treating physician seeking medical advice for this chronic disease, and they will not be stigmatized anymore and will increase the awareness for the treating physicians on how to treat obesity and the available options that we got, especially if we know that only 4% of people who are obese are offered treatment. And also will increase the chance that the authorities and stakeholders will consider obesity as a chronic disease and will make management and treatment options available for the public. The obesity epidemic is global, and worldwide the rate of obesity has nearly doubled since the year 1980. And now we have more than 500 million adults are affected with obesity. And estimated that in the year 2014, that is 6 years earlier, around 39% of adults are overweight and 13% of adults worldwide were obese. And this is not the only problem of adults, or this problem is restricted to adults, but it is the problem of childhood as well. And we are seeing a very rapidly increasing rate of childhood obesity among our children and kids. And it has been estimated in the year 2010, 43 million preschool children were either obese or overweight. And this represents a 60% increase over the previous 10 years. And in a study that was published in the year 2014 of obese and overweight in children and adults, they found worldwide that the proportion of adults with overweight or obesity has increased significantly. And this is were equally present in the developed and the developing countries. And this is very simple. The obesity rate has increased because of what is called the obesity or the obesogenic environment that we are living in. The availability of food that is tasty food with and cheap, available for everyone, unhealthy junk food that contains or consists of large portions with different types of recipes, the TV shows about the chefs and how to cook food, and the presence of many different types of appetizers. All of these has resulted in the obesity epidemic, and this is called the obesogenic environment. And as you know, obesity is a multifactorial disease. It's not just related to the environment. Genetics and individual characteristics also play a major role. So there are many genes that have been identified to cause obesity. That's why we are seeing many families with the whole members of the family are affected by obesity. Physical disorders that limit the movement of patients can cause obesity. Intoxication with substances, especially alcohol, unhealthy lifestyle, lack of exercise, sleep deprivation. Those who are shift workers are more likely to be obese. Mental distress, like weight discrimination, depression and anxiety disorders, in addition to medication use, and at the top of the list are corticosteroids and antipsychotics. All of these play a major role in the pathophysiology of obesity. And the ready availability of food is the major player actually. The food that is available nowadays is high energy dense food, and the problem, this food, which is junk food or unhealthy food, is palatable for us, while the low energy dense food, that is the healthy food, is more satiating but less palatable. So the low energy dense food are typically those that contain the most of water and the least fat, and are the least satisfying to the palate, unfortunately. So the bottom line seems to be that if there is food available for a human being, our tendency is to eat it. And you know that obesity is complicated by many disorders, such as type 2 diabetes, cardiovascular disease, GERD or gastric reflux disease, sleep apnea syndrome with all its deleterious consequences, cognitive disorders, especially depression, cancers like breast cancer in females and colon cancer in both genders, DVT, deep venous thrombosis, and osteoarthritis, and other complications. A very important disorder that is often overlooked is NAFLD, non-alcoholic fatty liver disease. Obesity is the major cause of or risk factor of non-alcoholic fatty liver disease, and NAFLD is the most common liver disease globally. And if NAFLD left untreated, it will be complicated by non-alcoholic steatohepatitis, which is called NASH. And NASH is one of the most common forms of NAFLD, and NASH is the major cause of liver transplantation nowadays. And it is very clearly that the increasing prevalence of obesity and diabetes have resulted in the increasing prevalence of NAFLD. And under the umbrella of obesity, we can find many psychiatric disorders. At the top of the list is anxiety and depression. It's not the problem with the other conditions or disorders, but there is a study that was published many years ago and involved around 1 million people worldwide, and they found in that study life expectancy decreases as BMI increases. So for a normal healthy individual with a normal BMI, it is almost 80% the chance of reaching age 70. And this chance will be reduced to 60% actually whenever the individual has grade 2 obesity, that is BMI between 35 and 40. And whenever the individual has morbid obesity with a BMI of more than 40, this chance will be even reduced to 50%. So why we should consider obesity as a chronic disease? First of all, obesity is a chronic relapsing disease of fat that is associated with impaired body function. So it is a chronic disorder. And we have seen many people who are struggling with getting rid of obesity. And once you get it, you will have it for the rest of your life, unless you are very lucky. Second point is that obesity, like other diseases, it results from physiological dysfunction. And the etiology of obesity is very well described. Thirdly, it ends with complications. It causes and exacerbates substantial number of significant comorbid conditions like diabetes, hypertension, and hyperlipidemia. And finally, obesity is associated with a substantial burden of morbidity and premature death, as I've shown you. And the loss of as minimum as 5 to 10% of our body weight will have a very great impact of many conditions. It will reduce the risk of type 2 diabetes. It will reduce the risk of cardiovascular disease. It will improve our lipid profile. It will improve blood pressure and reduce hypertension. A very important thing is it will represent the main step of treatment of sleep apnea syndrome. And finally, there will be improvement in health-related quality of life. And for those who are opponent to this notion of considering obesity as a chronic disease, they mention what is called the metabolically healthy obese. But for those who are metabolically healthy obese, they represent a small number of people, actually, or small percentage of obese people. They have a normal blood sugar, normal lipid profile, and there is no hypertension. However, these, as I said, they are relatively few if we compare it to the majority of obese people who are metabolically unhealthy, and they are likely over time to be shifted from the healthy side to the unhealthy side. And the problem of obesity is not only with the weight loss, but with the maintenance of what we've lost of our body weight. And weight loss is a challenging task in obesity because physiologically it is perceived as a dysfunction by our body. And there is a hypothesis called the thrifty gene hypothesis, which proposes that the ability to process and store fat had an evolutionary advantage for most of a human existence when energy resources could be scarce. And this is applied a million of years ago or thousands of years ago when the food was scarce. But this advantage has become with the time a disadvantage in eras such as our era, where the energy dense foods are abundant. So a corollary to the thrifty gene hypothesis is the notion that the body perceives weight loss as a dysfunction. And whenever we try to diet or exercise, our body will perceive that as a dysfunction and the result of either illness or food scarcity. Our brain cannot imagine that we are intentionally reducing our food intake, and therefore our body will strive to correct this by promoting hunger and weight regain. And this has been proved by many studies, as you can see here. So in people who were involved in programs and they started to lose weight, they followed up them by checking their hormones. And they found that with the losing weight, the satiety hormone, like leptin and peptide YY and amylin, all of these hormones reduce with the time. On the other hand, the hunger hormone, that is the ghrelin, increase with the time. So our body will perceive our trial to dieting and reducing our body weight as famine. And this is the reality. We are still obese with big tummy, with a lot of food, beside us, but the perception as if we are passing into a famine. So human physiology tends to perceive dieting to lose weight as akin to being in the midst of a famine, and as a result of that, the physiological imperative will become eat, eat, and eat. And all of you have seen the famous TV show, The Biggest Loser, and this TV show was a good opportunity for scientists to study obesity more. A very interesting finding is that those who who lost a lot of their body weight at the beginning, they regain most of what they've lost with the time. And also there is dramatic change in the basal metabolic rate 6 years later after the finishing of the TV show. So it is very important to manage patient expectations, and the clinicians need to understand the complexity of weight balance and obesity, from genetics to physiology to environment to behavioral changes. And patients also need to understand this as well. They should understand that obesity is multifactorial, and a great effort is needed to overcome this chronic disease. And the more the patients understand, the likelier they are to realize that being overweight and regaining lost weight are not the result of patient failures, and they shouldn't be stigmatized. Rather than this is our nature. This is the nature of our body. And weight problems are not matters of willpower. They are matters of our biology, and this is very natural. And similarly, patients need to understand the limits of diet and exercise interventions, and they should be offered medical therapy or surgical therapy for obesity because it is a chronic disease. Therefore, now we have many drugs available, and the approved agents are orlistat, liraglutide, naltrexone, papropion combination, and phentermine topiramate combination. But we have to admit, the most powerful and the most efficient way of getting sustained weight loss over 15 years is a bariatric surgery, especially the bypass surgery. So obesity needs to be reconfigured as a chronic condition, and early treatment response, the amount of weight loss from the baseline to a predetermined time point, is a predictor of ongoing weight loss in obesity treatment. Those who succeed in getting weight loss within a shorter period of time are those who are more likely to sustain weight loss for many years later on. And just as in the case with other chronic conditions like diabetes, hypertension, bronchial asthma, a suboptimal response to therapy should trigger a clinical evaluation by the physician, and we should search for the causes of such suboptimal response. And again, just as is the case with other chronic conditions, getting to a goal or stabilizing the patient does not entail stopping therapy. It's actually quite the reverse. Usually people need to continue on their therapy because it is a chronic disease. So to summarize this presentation, obesity is highly prevalent, and we are living in the epidemic of obesity, and it is a chronic condition that needs to be considered as a disease rather than a risk factor for other diseases. And obesity manifests as a number of cardiometabolic and other conditions, most importantly cardiometabolic, the diabetes, MI, stroke, cancer, osteoarthritis, and the sleep apnea. And obesity results from the dysregulation of a number of hormones and signaling pathways that influence appetite and satiety, as you have seen through the studies of the ghrelin and the leptin and other hormones. Finally, it is difficult to lose excess weight, and perhaps even more difficult to maintain weight loss. But a number of beneficial therapies are available, and now we have a good armamentarium to tackle obesity, and additional pathophysiological targets are being investigated. And thank you